and grading the data to present to the guideline development group that then will help us draft and write our guidelines. So in preparation for that, we have been examining the data. We do know the trials did enroll patients who are early in their symptom onset, so less than 5 days. So that is true. So that means someone has to know themselves that they, maybe I have COVID, and then get tested to get a confirmatory test. Also, the studies were done in high-risk patients, meaning that those are patients with at least one risk factor for severe disease or hospitalization. So I think that's another important aspect. We also know that the studies of molnupiravir, which is the trial data that we are looking at right now, did not give the drug to women who were pregnant. So that's another consideration in that drug and the safety profile of that drug. So we are looking at the estimates of effect from the studies. And so I can't tell you right now what the meta-analysis results are, because we don't have that yet. But we hope in about 3 weeks that we'll have a GDG meeting, because we're still need to carefully look at that evidence to write the guideline. In regards to other considerations, I think it's also important, we will be considering whether or not monotherapy, such as with one antiviral, may lead to resistance, and what that risk would be, as we've seen with some of the monoclonal antibodies, with just using one monoclonal antibody, there may be a risk of developing resistance. So that will be something we will also be looking at. And then as well, in preparation for any new drug, such as well as was done for the vaccines, good pharmacovigilance programs and practices need to be into place. So any place, low, middle income countries, high income countries, need to have a pathway to monitor the implementation of these drugs in the case that we do write the recommendation, to ensure that when it goes out in a bigger population, that the safety profiles are closely monitored, in addition to the virus itself and development of resistance or variants. Thank you. Over.
Thank you, Dr. Diaz. Dr. Simão?
Just on the issues, thank you, Janet, on the issues regarding the availability at country level, we very much welcome once the studies are concluded by WHO and if the small, we call these small molecules, they are pharmaceutical products. They are very welcome if they prove to be safe and efficacious, because of the capacity to produce in more places. There are more manufacturing capacity in the globe for pharmaceutical products that are not biotherapeutics like the monoclonal antibodies. We already have a few monoclonal antibodies in WHO's guidelines, and they face not only the problem of the difficult clinical management, but also the availability, and the production is very concentrated in few manufacturers. And with this type of antivirus, if they prove to be safe and efficacious, we do have already a voluntary license to several generic producers, which will increase the availability in the market. So this is potentially very good news.
Dr. Ryan?
Like with Mariangela, very much welcome these new data. I mean, one of the things we have been waiting for is effective small molecules, and relying on immunomodulators has been great. It saved lives, but having drugs that are directly able to disrupt the virus replication is very, very welcome. I think that we have to also remember that the primary prevention for COVID-19 is vaccination and avoiding getting infected in the first place. But clearly, having a second line approach of being able to treat those who do get infected is very attractive, and being able to save lives in that manner is very effective. So this is one of these situations where the strategy will have to evolve and have many layers in our strategy. Our primary strategy is to prevent infection. Our secondary strategy are prevent infection and prevent infection leading to severe disease, and in those infected to be able to treat high-risk people. And as Janet said, rolling out any new molecule at this stage, these molecules have been tested in hundreds of people. To extend these therapies to potentially hundreds of millions of people is going to take a very careful process to assure safety, pharmacovigilance, surveillance, and ensuring that the right patients, as Janet said, at least initially, high-risk patients in clinical settings are going to be able to access these drugs. And that does bring in the issue of having appropriate diagnosis both clinically and from a laboratory point of view. And what it speaks to is having well-integrated detection and clinical management systems that care for and support patients with oxygen, with anti-inflammatories, with these drugs, and at different stages of the course of disease. But to have a drug potentially coming down the pipe that can treat high-risk patients earlier in the course of disease is good news. But we wait to see the meta-analysis, we wait to go through the process. WHO will work with partners to ensure, under Mariangela's leadership, that we have the safest and most efficacious products available, and then obviously trying to get to the point where they can be produced at a price that people can afford. So I think it's all going in the right direction, but we just need to move step by step in a methodical way to ensure that clinical care for COVID can improve using these molecules. But we also have to focus on basic supportive care, oxygen, and all of the other things that we know at this point can save lives.
Next question, Carmen Baum from Politico. Carmen?
Hi, Terry. Thank you so much for giving me the floor. I just wanted to ask if there's been any update on the emergency use listing of Sputnik V. I know Dr. Shimao was talking about some I think, bureaucracy issues a few good weeks ago, and I was just wondering if there's been any progress on that in the meantime. Thank you.
Thank you, Carmen. What we had actually were some legal requirements that had to be clarified and signed by the applicant, which is the Russian Direct Investment Fund, which were signed a couple of weeks ago. I think I mentioned this in a presser. So the process has restarted. We are in conversations with the applicant, with the Russian government, the different parts of the Russian government, and we are expecting to have a meeting next week to receive the full. We still have to receive the full dossier from the Sputnik. There are pending issues regarding inspections to Gamaleya, inspections to the manufacturers, and there's a lot of interchange of information that still needs to happen until the process is concluded, but the process is moving again, which is very good news.
Thank you, Dr. Simão. We will now go to portal Euractiv, and we have with us, sorry for my pronunciation, Gidre Pesekait. Gidre?
Hi, do you hear me?
Yes, very well. Please go ahead.
Thank you for taking my question. So I have a question on European Union's role in COVAX initiative. I wonder what's WHO's view? Is the EU doing enough as a global player, and should it be doing more? And if you know, is the EU willing to do more, taking into account ACT Accelerator's new strategy that requires fundings of over $20 billion? So I wonder, again, what WHO is thinking of EU's input in COVAX, especially when countries in the region are already giving booster shots while only a few % of people are vaccinated in other parts of the world. Thank you.
Thank you. The line wasn't the best, but I think that the question was on COVAX and where do we stand with that. So maybe Dr. Swaminathan may start. Also, there was a mention about ACT Accelerator.
Thank you for that question about COVAX. As the DG said, COVAX is a mechanism that was really set up to address the equity issue in access, knowing from past experience that many countries and many people get left behind when there is a global need for a product. So it was set up as an end-to-end mechanism to invest, and we have a portfolio of 11 vaccines in the COVAX portfolio with advanced purchase agreements signed with those companies. The issue has been the supplies to COVAX has been slow. It's not been the first priority for companies to supply to COVAX. And this is where we've been urging all countries that have already vaccinated over 40% of their populations with a primary course to let manufacturers prioritize the supplies to COVAX. We need the visibility, we need the supply chain to keep moving. Countries are waiting for the supplies. And I think we've been highlighting the fact that we have over 100 countries today that have not vaccinated 40% of their population. So still a large number of countries. And we don't think we can get to that target that we have set by the end of the year unless we increase the supplies through COVAX. 500 million doses approximately have moved. We hope to get another 500 million out, but we are ready. COVAX is ready to ship doses. The European Commission has been a strong supporter. As you know, they set up the ACT Accelerator along with WHO, co-founded it, have put in both financial resources as well as a promise of donations of doses that have started flowing. But again, of all of the doses that have been promised as donations from countries around the world, almost 1.4 billion, less than 20% have actually, we've actually seen those. So again, very grateful for the donations of doses, but we need them to start flowing now, both from the countries of the European Union as well as from other parts of the world that have promised us doses. We need more resources. The ACT Accelerator just came out with a refreshed budget for about $23 billion, not just for vaccines, but also for the tests, for the treatments. As you just heard, we now have treatments that can protect high-risk people from getting into hospital and dying, even if they get infected. This has to go hand in hand with testing, obviously, with diagnostics, and for health systems support. So the European Commission has been a strong supporter of the ACT Accelerator and COVAX, but this is the time really to prioritize first doses to people who haven't had those primary doses and wait on the boosters at least till the end of this year. And let's try and get to that target of 40% of every country's population vaccinated, so we can see deaths going down. That's really the key here. Thanks. I don't know if anyone else wants to come in.
I just want to come in and take an opportunity to talk about Europe, just given the situation, because I think it's a balance of what's happening. You said what's the role of the European Union and whatnot, and all countries have a role to play in what's happening right now at the global level, at regional level, in countries. And one of the things we are seeing quite strongly in the data is how effective vaccines actually are in terms of reducing hospitalizations and reducing deaths, but they have to reach the people who need them most. And so it's not just about how much vaccine coverage there is, it's about who is being vaccinated, as the Director General said again in his speech today. And one of our colleagues, a brilliant colleague of ours today, said, it's not even just about who is vaccinated, it's about who isn't. And what are the populations that are missing the critical need for vaccination? People with underlying conditions, people who are over the age of 60, our frontline workers. And in far too many countries, those vaccines are not reaching those individuals. And even in the countries, we're seeing across Europe, across the world, transmission, is increasing. Transmission is driven by so many factors right now. The variants, increases in social mixing, which began months ago. The patterns that we are seeing across Europe, the patterns we're seeing across the world, are entirely predictable. Because when you lift public health and social measures, when you lift the rules around masking and distancing and improving ventilation, avoiding crowds, in the context of variants, in the context of increasing social mixing, in the context of limited vaccination, you're going to see the virus thrive. And that's exactly what's happening right now. In the Northern Hemisphere, we are entering the winter months. People will spend more time indoors. What we are saying to all countries right now is look at your situation, critically assess the situation that you're in right now, and make adjustments. Use the tools that you have, whatever tools you have right now, improving your surveillance, appropriate testing linked to public health action, getting that vaccine out, but also physical distancing, wearing of well-fitting masks, avoiding crowds. All of this will drive transmission down as we get vaccination coverage up. Because the deaths that are happening right now are just absolutely tragic because they can be prevented because we have tools. So we need to look at what's happening right now in every country around the world and make some course corrections using the tools and the capacities at hand, while at the same time fighting as hard as we can for vaccine equity to get those vaccines into the arms of the individuals around the world.
Please.
I just wanted to add one more point where I think the European Union and European Commission have been very active, and that is really in supporting the local manufacturing and production of vaccines and in particular supporting the concept of the multilateral technology transfer hubs. The European Union has pledged $1 billion to support manufacturing in Africa, and working closely with the African Union, with also supporting the new African Medicines Agency that has just been announced. I think there are many things that are going to happen now, and WHO is very happy and privileged to work with our partners to really support and enhance what's needed to set up manufacturing, not just for COVID vaccines, but this is something that's going to be more sustainable, building local capacity so that countries in Africa and in other parts of the world can address their own health needs and produce products which are needed for their own health conditions of their population. So that's another area of activity that we're working very closely with the European Commission on.
Thank you. We will now go to EFE News Agency, and we have Isabel Sacco with us. Isabel?
Good afternoon. Thank you, Tariq. I would like to know that if, given the strong increase of cases in Europe, this can justify to establish capacity restrictions for indoor activities, for example, for all that is public places, museums, fitnesses, cinemas, and if authorities should also consider to avoid again crowds, for example, in stadiums, sport events, and so on. What do you think about this? Thank you.
Maybe I can begin. Maria may come in. I think the situation is almost unique to every country right now. And the decisions that governments make are very much dependent on what phase of the epidemic you're in, if it's winter or if it's summer, what the background vaccination levels are, and what level of compliance can be expected from the implementation of personal measures versus government mandated measures. I think what's clear, and Maria spoke to this, that in many countries who've achieved 30, 40, 50% vaccination coverage, it is clear that that 30, 40 or 50% does not include the people who are most vulnerable. In countries that have high vaccine coverage, and where in particular within that vaccine coverage they've covered high risk and vulnerable people, we are seeing an increase in disease incidence. But we're not seeing the health systems necessarily come under pressure, because that's not translating into very, very sick patients. In other countries with maybe lower levels of vaccination, or countries who think they have a high level of vaccination but have significant pockets of vulnerable people unvaccinated, the same incidence or even lesser incidence of disease will lead to pressure on the health system. And all of that in terms of transmission is driven by social mixing. And that's mixing in the home, mixing in any environment. And the more dense that mixing is, the more intense that mixing is, and the more that mixing happens in a situation where people are not taking precautions, or in poorly ventilated circumstances, or spending a long time with large crowds in indoor spaces, we've said it, we keep saying it, that is still a high-risk undertaking, particularly in a situation where you have low vaccine coverage and where you have existing high incidence at community level. So each and every country, and Maria has just said it, needs to take a step back, needs to look at the epidemiologic situation they're facing, needs to do a deep dive on who exactly is vaccinated, and as Maria said, who exactly is not vaccinated, who are the unvaccinated. Because if you have a significant number of individuals in your community who remain unvaccinated, who are at high risk of disease, and you have intense community transmission, your health system will begin to come under pressure. There are a number of ways to try and avoid that scenario. Boosting vaccination, and in terms of numbers of people who are vaccinated with 2 doses of the 2-dose vaccines, a dose of the single vaccine in high-risk areas. That we've spoken before about the use of third doses or booster doses in people with immunocompromise and people with very, very high risk of disease. And then looking at what measures at societal level will help to reduce the intensity of that transmission and take the pressure off the system. Some countries are facing a very difficult situation, and they may need to put in place very stringent measures. Other countries may have opened up slightly too quickly and have completely taken away all measures, masks taken away, no restrictions on gatherings, no restrictions on crowds. And in a situation like that, where you have intense transmission with low vaccination, you're going to be in trouble. So I think each country will have to look at what measures can be put in place to reduce the intensity of transmission. And that is both an individual responsibility for all of us. Transmission should stop with you. And knowing your status, and if you are sick or unwell, stay away from work, stay away from school, stay away from contact with others, get tested, find out your status, and ensure that if you are COVID positive, that you're properly followed up and there's contact tracing done for you and anyone else you've been in contact with. All of the things we've spoken about before in terms of trying to stop chains of transmission. I think, quite frankly, some countries are in such a difficult situation now that they're going to find it hard not to put in place restrictive measures, at least for a short period of time, to reduce the intensity of transmission. Other countries are maybe not too late. Other countries can maybe re-engage with communities around masks, around avoiding crowded spaces, around limiting their contact with others, work from home, and many other initiatives. And very importantly, increasing vaccine coverage in high-risk populations. Maria, I don't know if you've stuff to add.
I only want to comment on the timing. So one of the things we keep saying is do an assessment, reassess the situation, and take action. The earlier those actions can be implemented. Potentially the less actions need to be taken. So what we're seeing is countries, they're reaching a point where cases are increasing again, hospitalization rates are increasing again, ICU capacity is increasing, and these interventions that are coming back into play, the wearing of the mask, the physical distancing, the working from home, are coming into effect too late because you're already in that exponential growth. And remember, we have the Delta variant right now, and Delta is 100% more transmissible than the ancestral strain. It's the most transmissible virus we've seen so far. So when we say do regular assessments and assess where you are and take action, it's about the timeliness, not only what you do, but the timing of when you implement those measures. And the idea is to avoid having to put all of the measures in all at once, but to have that layered approach and have a tailored approach using what is needed in the most local level possible for the least amount of time needed. Otherwise, the transmission takes off too quickly, you have too many cases, the healthcare system gets overburdened, and then you have to just slam down and go into these so-called lockdowns. And that's what we need to avoid. So it's not only about what is implemented, it's about the timeliness of those interventions, how they are layered, and how they are adjusted. Because it's quite confusing for people out there to know what to do. The rules change all the time, the messages change all the time, and we can understand that, from an individual level measure. And so what we commonly say is know what your risk is at an individual level and take measures to lower your risk every day, because the situation is so different around the world. And for leaders to have clear communication about what needs to be done and when, so that people know how to keep themselves safe. So it's a combination of approach. Some people like the Swiss cheese approach as opposed to the comprehensive approach that we say. Whatever works for you, use it. But it's about a combination of factors, a combination of interventions. And then lastly, on spending time indoors, this is an important part of your question. One of the things we've been working very hard on with governments, with industry, is to improve ventilation in the places where we live, the places we work, the places we study. And that requires an investment. Quite simply, you can open the windows, if it's safe to do so where you are, but an investment in ventilation takes time. And that is something we've been working on with countries to improve. But those investments need to happen now.
And again, re-emphasizing the point for all of you out there, if you're in Europe right now, where we've got that intense transmission, and you're in a high risk or vulnerable group or an older person and you're not vaccinated, your best bet is to get vaccinated. There's some excellent data coming out of European countries, and particularly out of the United Kingdom, and I think the recent estimates at the beginning of the month was that a vaccinated person, an unvaccinated person, has a 32 times greater risk of dying in this pandemic than a vaccinated person. That's very good odds if you just want to look at that in terms of something that enhances your chance of life. So, you know, make that decision if you can. Go out and get the vaccine, because not only will that help the health system cope, but it will protect you and your family. So vaccination and getting vaccinated if you're a high risk or vulnerable person, older person, is absolutely critical at this point in any of the European countries.
Thank you, Dr. Herrera and Dr. Van Kerkhove. We will now call on Simon Ateba from Channel News Africa. Simon?
Thank you for taking my question. This is Simon Ateba with Today News Africa in Washington. Ethiopia seems to be on the brink of a civil war right now, or at least on a very dangerous path. Can you give us an update on your activities there? Do you even have access? Are you ready to provide health care to people as things continue to worsen there? Thank you.
Thank you, Simon. For this question, Dr. Ryan.
I was just looking for my notes there. Thanks, Simon. No, the situation you outline is grave, and it's the situation in Ethiopia in general, but in particular in Tigray, continues to deteriorate. But we're in a situation now where not only Tigray but many other areas in Ethiopia are threatened by this situation. We continue to have massive difficulties in accessing populations, in running operations, in maintaining security, and obviously in the current situation, the UN is further interrupted by the recent detention of our staff members in Ethiopia. And we hope for their very fast release. So we've got issues in terms of logistics, in medical access, in running our operations on the ground, and this is not just us. World Food Programme have similar obstacles in their operations. So it's exceptionally important that we have humanitarian access to all people in need in Ethiopia, to all people in need in Tigray. That is not the case at the moment. That is frankly not the case, and we are struggling to even maintain the most minimum of services right now on the ground. And the risks are growing. People are dying. People are starving. People are dying because of lack of access to the very basics of medical care. The very basic human right to life is now being lost, and it's an unfolding tragedy, and it's unfolding before our very eyes, and the world needs to wake up to what's happening.
Thank you, Dr. Ryan, and apologies to Simon. It's Today News Africa. We will now ask John Zarakostas from The Lancet to join us and ask the question. John?
Yes, good afternoon. I'd like to briefly follow up on my colleague's question, but I've got one for the Principal Legal Officer, who I understand is there. If you could bring us up to date on how the talks are going between the various parties on finding common ground for a pandemic treaty to see something happen at the end of the month, how those talks are going. And with reference to the crisis in Ethiopia, I was wondering if Mr. Ryan could bring us up to speed if there are any contingency plans in light that the situation could unravel even more than the dramatic language he just used.
Thank you, John. We will start with Mr. Steve Solomon.
Thanks very much for the question. So there has been a formal member state process to prepare for the special session of the Health Assembly. The special session begins on November 29th and will last for 3 days. That formal process has concluded its work for the special session with a report that will go to the Assembly. At the moment, there is an informal process, also open-ended, which means all member states, all 194 countries can participate in this informal process to develop an outcome document of the special session. That is to say, a decision or a resolution of the special session, which will address itself to the question, the only question for the special session, and that is the consideration of the benefits of a convention, agreement, or other international instrument for pandemic preparedness and response. It's a very active process that member states are engaged in. They have the full support of the Secretariat and the Director General in their work, and there is good reason to believe that they will come to a successful conclusion.
And John, could I just ask you to repeat the specific question on Ethiopia?
John, are you still with us? Can you repeat a question on Ethiopia, please? You need to unmute, please.
Yes, Dr. Ryan, can you hear me now? Yes, I presume so. Yes, if I could follow up on my colleague's question earlier, given the dramatic situation on the ground as you described it, and the high risk that it could unravel even more, are you putting in place contingency plans for a catastrophic situation of a full-scale war, as some generals have warned in the last day?
We very much hope that will not be the case, because the consequences of such events would be catastrophic. But we always have within our planning for any event, doesn't matter what it is, we have our current expected scenarios, but we also have worst and worst case scenarios. So we always plan for what we think will happen, but we also plan for the unthinkable. And yes, John, we're always aware in Yemen, in Syria, in Afghanistan, in Ethiopia, and in other situations that there are multiple future scenarios. But there are ways to avoid those scenarios. We've had the means to avoid the suffering that's happened already in Ethiopia. This hasn't been a natural disaster. The Tigray has been a man-made disaster. It has been driven by the blockade of aid to a whole people. And that scenario, worst case scenario for the people of Tigray, has already unfolded. And if this continues, and if politicians continue to push this country to the edge, then the people can only suffer. That's the reality of the situation on the ground. We can only respond to the humanitarian consequences of the decisions of people who we have no control over, and everyone needs to look now to the health, the well-being, and the survival to all people in Ethiopia, to all Ethiopians, and to find a way to de-escalate and to find a peaceful path. The Director General, Dr. Tedros, always talks about the best path is peace, and we need health for peace, but now more than ever we need peace for health. But as I said, the reality is that the drivers of this disaster are man-made. These are human-made disasters, and the continued blockade of aid and the continued restriction of our UN partners' ability to operate, particularly in Tigray, is causing the loss of life, and it is causing massive pain and suffering. So it is time for something to be done to change that. But this has been the case. This didn't happen yesterday. This has been going on and on and on, and people have been speaking up and up and up, but we haven't seen action that would reduce the pain and suffering of the long-suffering people in the situation that they find themselves.
Yeah, thank you. Mike had already covered most of it, but I think the question is repeating. So I would be happy also to add a bit. So thanks to both who have asked this question. I mean, the situation in Ethiopia is really distressing. And of course, until recently, the crisis was in Tigray, but now the war has spread to Amhara and Afar regions. So the number of people who have been affected is more than 7 million now, but most of it still is in Tigray, 5 million people who need food aid. And this has been the case for more than a year now. No medicines, people are dying because of lack of supplies. We cannot send supplies and medicine to Tigray because it's under blockade, and the blockade is systematic. So no medicine, people are dying, no food, people are starving, no telecommunication, they're isolated from the rest of the world, no fuel, no cash. So it's under effective blockade. So you can imagine the impact of that on the health of people. Not only all the health problems that are deteriorating, but also mental health, for more than a year now, under full stress because of the blockade. But even more, as you know, ethnic Tigrayans are being profiled and arrested in mass, in thousands. This is blatant and open. And imagine how that also affects the health of many millions. So from our side, because of the blockade, we are not supporting the people who need support, because it's under full blockade, circled almost all directions. So there is no access, and I don't think we can give you that much figure on what kind of support we're giving, because it's really too small, and especially the last few months, no supplies, no medical supplies or medicine has entered the region because it was prevented from getting to the region. Medicine supplies were prevented from getting into the Tigray region. So our activities to the minimum, almost you can say, it's almost nothing. Thank you.
Thank you, Dr. Tedros, Dr. Ann, and Mr. Solomon. I think we will go to our last question for today. We have a Z News from India and Pooja Makar online. Pooja, can you hear us?
Thank you for taking my question. Good evening. My question is on booster dose. Is it needed at all, or will it be must for all? What is WHO's take on it? More than 30 countries are already administering a booster, though evidence from breakthrough infection and secondary infection in India show that COVID is generally affecting one mildly post-vaccination. Thank you.
Thank you for that question. I think this is a very hot topic, and it's, we see, as you mentioned, a lot of countries doing boosters. So WHO is basically following the science and the data. So we have the scientific evidence based on which we will make the recommendations. And as you know, we have the strategic advisory group of experts that makes the policy recommendations on vaccines. So they're tracking the studies around the world very closely. And we really need more, high quality data coming from more countries, because the more representative the data that we can base our guidance on, the better. Right now, there's high quality studies coming only from a couple of countries and only on a couple of vaccines. So I think there is a lot of scope for many countries, including India, to really start providing more data from the populations because of huge numbers of people who've been vaccinated. And what we would like to see is data on breakthrough infections, mild, moderate, severe, leading to hospitalizations and leading to death. Now, what was mentioned earlier also by Dr. Ryan and Dr. Maria was the fact that the surges that we're seeing in many countries today, including in Europe, are resulting in hospitalization and deaths largely among the unvaccinated groups, especially if those unvaccinated people are older people, vulnerable, with comorbidities. So I think the bottom line is that vaccination with any of the approved vaccines is protecting to a large extent against becoming seriously ill. You can still get infected, but the protection against severe disease is high, even with the Delta variant, which does cause you some reduction in protective efficacy, but it's still extremely high. And so what's driving hospitalization and deaths today globally is the unvaccinated across the world, in countries which have lack of supplies, but also in countries which have enough supplies. It's that 30–40% of people who are still not vaccinated. So I think this is where countries need to focus on reaching those populations rather than on giving additional doses to those who have already received a primary course, except, of course, we've said repeatedly that, people who have underlying immune conditions which don't allow them to mount a good immune response, they might need a third dose. But the majority of people today globally who are falling sick are those who have not had their primary course. So this is where I think countries need to look at their own populations and try to prioritize, get the second dose to people who've only had one dose, reach all those vulnerable groups before we start doing boosters, because we have limited supplies. And also share countries which have excess supplies, which have already vaccinated their priority populations. Let us share with those countries which have not. There's a 25-fold difference today between countries, high and upper middle income countries, in doses per 100 people compared to the low income countries. So that inequity needs to be addressed. And as Dr. Ryan and others have said, vaccines are a very good tool that we have, but we need to continue to use the other tools because this virus is still transmitting and circulating quite actively and aggressively globally. So we cannot let down on the other public health measures. So it's a combination. Thank you.
Thank you, Dr. Swaminathan. With this, we will conclude this press briefing. I understand Dr. Ryan would like to add something.
No, I just on a personal note, I just want to note the passing of Dr. Chris Bartlett, who died on the 1st of November in the United Kingdom at the Royal Marsden Hospital. Chris Bartlett was led public health in the Communicable Disease Surveillance Centre in the UK for over a decade, the United Kingdom, and was one of the people. In fact, when you see the power of public health and public health measurement and surveillance in the United Kingdom today, Chris was one of the people who delivered on that and revolutionised public health and surveillance in the United Kingdom. But not only that, was an instigator of the European Centre for Disease Control, the EPIET training programme, and others. And I just wanted to extend on behalf of myself, the Director General, and the World Health Organization, our recognition of the career and life of Chris Bartlett and all the people that worked with him, and to pass our condolences to his family. Sometimes we should measure the heroes that pass, who created the systems that we now rely on for, as is in the case of the United Kingdom, some superb public health systems that exist there for measuring health impact, and Chris was a major part of that. Thank you.
Thank you, Dr. Ryan, indeed. We will be sending the audio file from this press briefing shortly after, and the transcript will be available tomorrow as per usual. Last word is for for Dr. Tedros.
Yeah, thank you so much, Tariq, and thank you to all media colleagues who have joined today, and see you next time.